Good afternoon from Chicago and welcome to the 2020 Virtual AVLS Annual Congress. I'm speaking to you this afternoon from the AVLS offices in Chicago. I'm only sorry that we all couldn't be together this year to do this, although I'm glad everybody is able to join us for what I think so far has been a really good program. My name's Mark Meisner. This afternoon I'm going to be talking about an AVLS project involving an international multidisciplinary panel which has been underway for the past 2 years with the goal of creating a discriminative classification instrument similar to SVP for pelvic venous disorders. And Fedor's talk was a very nice lead in for this, because what we're going to talk about is an instrument that's very similar to SVP for pelvic venous disorders. And from the start, I have to say that this is an introductory talk. You are undoubtedly going to come away from this with the impression that what I think is a fairly straightforward classification is overly complex, but I would caution you to read the manuscript and start applying this to patients before passing judgment. Just as I think we all know that when SVP was initially introduced, it took a couple of iterations for SVP for it to be widely accepted, and now it's part of our daily language and lexicon. You may have a similar impression of the SVP classification when you initially see it, but I think, as I'm going to say at the end, you have to read this and reread it and actually apply it to patients, and I think you'll find that it makes a great deal of sense. I don't have any disclosures relevant to this presentation at all, and I think, as we all know, pelvic venous disorders are currently defined as a variety of historic syndromes, most notably the pelvic congestion syndrome, which was independently described by Taylor and Lowe in 1949. However, looking more closely at the initial descriptions, which persist to this day, they are incredibly naive and bear very little relationship to what we currently view as pelvic venous disorders, and it's a little bit of mystery why we still use these. At least one description attributed an array of pelvic symptoms to women to the use of very strong corsets, which I don't think any of us believe is a significant pathophysiologic factor today. And I would submit to you that continuing to use these historic syndromes has no more value than attributing them to cooties, and we have to move beyond this a little bit. This misleading historic nomenclature includes the May-Thurner syndrome, associated with symptoms of lower extremity edema, heaviness, aching, throbbing, and venous claudication. The pelvic congestion syndrome, which is generally considered to include female patients with chronic pelvic pain, and the Nutcracker syndrome, associated with left renal vein compression and symptoms of flank pain and hematuria. However, these syndromes are very imprecise, with overlapping symptoms and clinical presentations. Both left common iliac obstruction and left renal vein compression can cause pelvic pain, while syndromic nomenclature does not account for varicoceles in males, also a pelvic venous disorder, which may be due to left renal vein compression, and it doesn't account for extrapelvic symptoms, which any of the three syndromes may also be associated with. The associated chaos has been associated with inaccurate diagnosis, poor treatment outcomes, and research limitations, since these syndromes do not define homogeneous groups. We clearly need a more rigorous and logical system of classifying pelvic venous disorders. This lack of clarity in the management of pelvic venous disorders prompted the Society of Interventional Radiology to sponsor a multidisciplinary consensus panel in October 2017 to identify the critical research priorities in pelvic venous disease. Among the 5 identified priorities, the development of a discriminative classification instrument similar to SVP for pelvic venous disorders was deemed the second most important priority after the development of evidence-based diagnostic criteria. Based upon these priorities, the American Vein and Lymphatic Society, your society, organized an international multi-specialty pelvic venous work group with the charge of developing a discriminative instrument for pelvic venous disorders. We held our first meeting in these offices on July 27, 2018, and you can see that we had 16 delegates from 9 international societies involving pretty much the whole spectrum of people who care for women and men with pelvic venous disorders, including the American College of Gynecology and Obstetrics, the International Pelvic Pain Society, the Society of Interventional Radiology, the European Venous Forum, the American Venous Forum, and the others as shown here. As a discriminative instrument, this instrument is designed to place patients into homogeneous groups and is not a severity score or an outcomes instrument, much as Fedor said, and I'll repeat that several times during this talk. and as such, it can be regarded very similar to SEEP. The resulting instrument is the SVP classification, which stands for Symptoms, Varices, and Pathophysiology, and is organized similar to SEEP, which everyone is familiar with. But before discussing the classification system, we have to understand the clinical presentation, anatomy, and pathophysiology of pelvic venous disorders. I'm going to spend a few minutes going through that now. Before we get to that, it's important to recognize that this instrument is designed as a discriminative instrument, not an evaluative instrument. That is, it includes key features of the disease that are stable over time, at least in the short term, and it carries no implication of disease severity, and it's unresponsive to longitudinal change. It is therefore not an outcome instrument. It's specifically designed to be patient-centric. It's not based primarily on an anatomic lesion, but what the patient presents with. It focuses primarily on the patient's presenting complaints rather than the underlying anatomy. From a simplistic standpoint, the goal of SVP is to place patients into bins with similar clinical features, natural histories, and response to treatment, with the goals, very much like SEEP, of facilitating communication among providers, defining treatment algorithms based on patient presentation, allowing subsequent development of evaluative instruments such as severity scores and patient-defined outcome instruments as well. The fundamental tenets of SEEP, sorry, I'm a little bit ahead of myself, but statistically, the SVP instrument is designed as a discriminative instrument. That is, as I talked about, it includes key features of the disease that are stable over time. It is designed to be patient-centric, as we talked about, and it can be regarded as very similar to SEEP, with the evaluative component of SEEP being the Venous Clinical Severity Score, as shown here. Pelvic venous disorders aren't yet advanced enough that we can develop a clinical severity score. Before we do that, we have to have the evaluative instruments such as SEEP. The SVP classification is based upon the complex interaction between anatomy, hemodynamics, and symptoms. The final manuscript is under review by the endorsing societies, and we anticipate concurrent publication in the Journal of Vascular Surgery and Phlebology this fall. Unlike lower extremity venous disorders, which are classified by SEEP based upon signs, and this is very important, pelvic venous disorders present with 4 groups of symptoms. That is, the SVP instrument is entirely symptom-based, not sign-based, because signs aren't quite as important in a patient-centric instrument for the pelvis as it is in the lower extremities. These 4 groups of symptoms include renal symptoms of flank pain and hematuria, chronic pelvic pain in women, pelvic origin extrapelvic varices in the vulva or scrotum or in the posterior medial thigh, and leg symptoms, including pain and edema. But the classification is much more complex than symptoms, as similar symptoms may arise from different underlying anatomy and pathophysiology. For example, chronic pelvic pain may arise from either primary ovarian vein incompetence or left common iliac venous compression, while similar underlying anatomy and pathophysiology may lead to different symptoms. For example, left common iliac compression can cause either leg or pelvic symptoms. To understand why this is so, we must have a thorough grasp of pelvic anatomy and pathophysiology, and I'm going to spend a few minutes going over this. Pelvic venous anatomy is much more complex than lower extremity anatomy and consists of 4 interconnected venous systems: the left renal vein, the left and right gonadal veins, the internal iliac vein and its drainage through the common iliac vein, and the lower extremity veins, the common femoral vein and the saphenofemoral junction communicating with the pelvic veins through the deep and superficial external pudendal veins, and the inferior gluteal vein communicating with the leg through the profunda femoris vein. These 4 major draining veins are connected by 4 venous reservoirs, which is where increased venous pressures are transmitted, varices develop, and symptoms occur. These 4 reservoirs include the hilum of the left kidney, the venous plexuses of the pelvis, which are essentially, in women, the uterovaginal venous plexus, which communicates with the ovarian plexus. In men, which is why some of these symptoms may be somewhat different in men, they don't have the extensive communication between the ovarian, uterine, and vaginal plexus, lacking those entirely, but having a prostatic plexus instead. And that field really hasn't been developed very much so far. the pelvic origin extrapelvic varices, and lastly, the lower extremity reservoir is shown here. As I mentioned, symptoms are presumably related to increased pressure and distension of each of these venous reservoirs. As elsewhere in the venous system, increased venous pressure may arise from either reflux or obstruction. In the pelvis, reflux arises largely in the gonadal and internal iliac veins, while obstruction occurs in the left renal and common iliac veins. Now, the question arises as to why similar symptoms can arise from different underlying anatomic lesions, while similar anatomic lesions can lead to different symptoms. And the answer lies as to whether increased venous pressure from reflux or obstruction are compensated by collaterals. And we're going to go through a little bit the concept of compensated versus uncompensated hemodynamics. If reflux or obstruction is not compensated by adequate collaterals, increased venous pressure is transmitted directly to the upstream venous reservoir and symptoms occur there. While if compensated by collaterals, pressures may be transmitted to more distal venous reservoirs. Thus, in uncompensated obstruction of the left renal vein, pressure is transmitted directly to the renal reservoir, and the patient, if symptomatic, will present with symptoms of flank pain and hematuria. Similarly, for uncompensated obstruction of the left common iliac vein, pressures are transmitted directly to the leg, and the patient will present with symptoms of aching, heaviness, and perhaps venous claudication. Consider the opposite situation with compensation via collaterals. In the case of the left renal vein, if this is compensated, the pressure is transmitted via the left ovarian vein to the pelvic reservoir, and the patient may present with pelvic symptoms if they're symptomatic. And for compensated obstruction of the left common iliac vein, pressures may be decompressed through the internal iliac vein, similarly leading to pelvic symptoms rather than leg symptoms. We have a very similar scenario for uncompensated reflux, considering uncompensated reflux in either the left ovarian vein or the left internal iliac vein. Pressures are transmitted directly to the pelvic reservoir, and the patient will present, if they're symptomatic, with pelvic symptoms. In contrast, in compensated reflux, we get transmission of the pressure through the recognized escape points in the pelvic floor to the leg reservoir, and the patient presents primarily with symptoms of pelvic origin extrapelvic varices, as we previously discussed. Central to all of this is the anatomy of the internal iliac vein, because the internal iliac vein really functions to connect the left renal vein and the left ovarian vein with the pelvis and the pelvic circulation, also connects the pelvic circulation through the escape points with the lower extremities, and also connects the left common iliac vein through the internal iliac vein with the iliac venous system. The internal iliac vein is thus central to the communication between the venous disorders of the pelvis and the lower extremity. The distal tributaries of the internal iliac vein function very much as perforating veins, connecting the deep veins of the pelvis with the superficial veins of the lower extremity. The internal iliac vein is formed by, as far as the parietal tributaries go, the confluence of the obturator vein, the tributaries of the inferior pudendal vein, and the inferior and the superior gluteal vein, as shown here. These allow pressure transmission through these distal tributaries through recognized pelvic escape points, the obturator point, the inguinal point, the perineal point, and the gluteal point to the lower extremities. Importantly, these also communicate with the saphenofemoral junction through the superficial external pudendal vein, and also the inferior gluteal vein can communicate with the profunda femoris vein as well. And as I mentioned, this really makes the internal iliac vein central to the communication between the renal veins, the iliac veins, and the lower extremities, and functions very much as the gateway to the leg that's exactly analogous to perforating veins connecting the deep veins of the pelvis to the superficial veins of the leg. So now to return to the SVP classification system, after understanding a little of the anatomy and hemodynamics, the SVP classification system is based upon this complex interaction between anatomy, hemodynamics, and symptoms, and has three primary domains. Symptoms, the involved variceal reservoirs, designated V, and the underlying pathophysiology, including the anatomic segments involved, the hemodynamic abnormalities, whether this is due to reflux or obstruction, and the underlying etiology. This is exactly analogous to the EAP domains of SEEP. An individual patient's classification is designated by subscripts for S, V, and P, P including the anatomic, hemodynamic, and etiological components of P, as shown here, separated by commas. The subscripts for both symptoms and varices domains are based upon dividing the pelvic venous circulation into 4 anatomic domains based upon the involved venous reservoirs, the same 4 that we just talked about, and their primary drainage pathways. So zone 1 at the top is drained primarily by the left renal vein as is associated with renal symptoms of flank pain and hematuria, and in uncompensated obstruction, varices in the renal hilum. Zone 2 includes the pelvic drainage pathways of the ovarian and the internal iliac veins. Symptoms include chronic pelvic pain in females, and varices occur in the venous plexuses of the pelvis. Zone 3 represents the transitional veins exiting the pelvis and includes vulvar and scrotal varices, as well as venous claudication. Zone 4 includes the major superficial and deep veins of the lower extremity, and Zone 4 is primarily classified with SEEP, not SVP, and Zone 4 is the overlap between SVP and the SEEP system. Moving on to the pathophysiology domain, similar to SEEP, the pathophysiology domain includes a precise definition of the venous segments involved, which are designated in alignment with SEEP, the underlying hemodynamics, whether due to reflux or obstruction, designated as R or O, and the underlying etiology, whether thrombotic, non-thrombotic, or congenital. Each of these is designated as a subscript to P, such that it reads much like a sentence. For example, P left CIV, O, and T is read as non-thrombotic left common iliac obstruction. The designation may appear more daunting than if you simply read it as a sentence, non-thrombotic obstruction of the left common iliac vein, as shown here. This is an introductory talk, and it would be unreasonable to have anyone come away from this 15-minute talk with a working knowledge of this classification system. The manuscript must be read, studied, and applied to patients. However, I will give an example of its utility. Consider chronic pelvic pain of venous origin. This has historically been referred to as the pelvic congestion syndrome. However, it may be due to ovarian or internal iliac vein reflux, left renal vein compression, or left common iliac obstruction, all of which are obviously treated quite differently. The SVP classification allows these to be clearly differentiated rather than thrown into a single bin, such as pelvic congestion syndrome. For example, bilateral ovarian vein reflux, as shown here. The symptoms occur in the pelvis, zone 2, therefore it's designated S2. The varices occur in the pelvis, so it's a V2, and the pathophysiology is reflux that is non-thrombotic of the bilateral gonadal veins, BGV, R, and T, as shown here. Now consider a similar symptomatic presentation resulting from left renal vein compression, formerly known as the nutcracker syndrome. Again, symptoms occur here again in the pelvis, so it's S2, but varices involve both the renal hilum, as shown by the dashed white arrow there, as well as in the pelvis at the bottom. The pathophysiology is left renal vein obstruction, non-thrombotic, and left gonadal vein reflux, non-thrombotic. Similar symptoms, but designated very differently than bilateral ovarian vein reflux. Finally, pelvic symptoms can also arise from left common iliac vein compression. Again, symptoms occur in zone 2 in the pelvis, so it's an S2. The varices are in zone 2 of the pelvis, V2, but in this case, the pathophysiology is non-thrombotic obstruction of the left common iliac vein associated with non-thrombotic reflux of the left internal iliac vein, as shown here. It's recognized that this classification is relatively complex, but pelvic venous disorders are complex. To assist new users with adoption, the manuscript does include a scoring sheet. In addition, Tony Gasparis has developed an app for both the iPhone and Android platforms. The user just checks each component of the classification, symptoms, as shown here, as well as where the varices are, as shown here, and the application generates the classification, as shown here. So in conclusion, Pelvic venous disorders are complex, and they're made complex by the fact that similar clinical presentations can have different underlying pathophysiology, while similar underlying pathophysiology may have different clinical presentations. And use of these historic syndromic terms don't do justice to these differences. This historical syndromic nomenclature is misleading, contributes to inaccurate diagnosis, poor treatment outcomes, and very limited progress in research, since we really can't develop the outcome instruments necessary to study this until we have a way to classify it. It should be obvious that a new discriminative instrument is desperately needed, and this is the SVP instrument, which is complex, but as above, pelvic venous disease is complex, and the very same thing has been said multiple times about SEAT, most recently at the American Venous Forum meeting in February with the new revision. It is important to read and reread the manuscript, use the app once it's available, and practice it on patients. Thanks very much for your attention this afternoon. I hope you're enjoying the meeting and continue to enjoy what's still coming up ahead. Thanks very much. I'd be happy to answer any questions.
Mark, it looks like we have no questions from the audience at this time.
Maybe it's not nearly as complex as I thought it would be.
I'm sure it's not, and I'm sure they're looking forward to the publication.
Thanks very much, Dean. Have a good afternoon, everyone.